to pass. Thank you, Senator Lotto. Whenever you're ready to move to item number 8, SB 291, please do.
Thank you, Mr. Chair and members. Before I begin, I want to say thank you, and I accept the committee suggested amendments and thank your staff for their work on this issue. With the committee recommendations, this bill will now require both the Department of Health Care Services and the Office of Health Equity to include stakeholders with trauma related to genocide expertise, and will also expand the definition of vulnerable communities. As you know, serious incidents of trauma have long-lasting impacts on the mental health and well-being of many Californians. Many immigrants come as refugees of serious oppression or, in the most severe cases, genocide in their countries. SB 291 will help communities and nonprofit organizations who serve individuals with trauma related to genocide access appropriate mental health services. I thank you for your support and respectfully ask for a vote.
Thank you, Senator Lotto. Witnesses in support.
Good afternoon, Mr. Chair and members. My name is Kat New. I'm here on behalf of the Cambodian Advocacy Collaborative, which is a partnership among 5 of the largest Cambodian-serving organizations in Long Beach that include the Cambodian Association of America, Families in Good Health, Khmer Girls in Action, Khmer Parent Association, and United Cambodian Community. The collaborative is grateful for Senator Lara for highlighting the Cambodian community and championing SB 291. The collaborative fully supports SB 291 to increase access to communities that have experienced trauma related to genocide. 40 years ago, during the Cambodian genocide, over 2 million Cambodians were executed, starved, and worked to death. Survivors experienced horrific traumas, including rape, torture, and witnessing the death of friends and families. This compounded trauma was amplified through experiences living in the refugee camps and immigration into countries such as the United States, and transitioning from a predominantly rural environment to one that is urban, high crime, poverty-stricken, and filled with racism. Overall, Cambodian genocide survivors experienced an average of 15 major traumatic events. And now, 40 years later, the Cambodian community is still recovering from trauma. One study shows that 62% of Cambodian adults have post-traumatic stress disorder and 52% have depression. Left untreated, the trauma develops into chronic health conditions. Nearly 50% of Cambodian Americans have 5 or more chronic health conditions that include diabetes and high blood pressure. Cambodian Americans are getting sick and dying at an earlier age than the general population. 26% of Cambodian Americans die between the ages of 45 and 64, compared to 18% of the overall California population. These poor health and mental health conditions and complex trauma are intergenerational. Research shows that trauma increases levels of cortisol in the body, and this persistent level of stress hormones is physiologically inflicted upon the children and those who experience trauma. In addition to biological effects, youth also develop poor coping mechanisms because of their disengaged parents who are living through PTSD and depression. A participatory action research project conducted by Khmer Girls in Action shows that 1 out of 2 Cambodian American youth has depression symptoms. These health and mental health disparities in Cambodian American youth are manifested in low educational attainment. The collaborative believes SB 291 increases access to communities that experience trauma and related to genocide by including this unique vulnerable population to key state departments, plans, definition, mission, stakeholder groups. We urge your support for SB 291. Thank you.
Thank you. Additional witnesses in support, please.
Kimberly Chen with the California Pan-Ethnic Health Network, proud to support SB 291 and urge aye vote. Thank you.
Additional witnesses in support.
Chair and members, Sean South on behalf of the California Primary Care Association in support.
Mr. Chair, members, Jean Hurst here today on behalf of the Santa Clara County Board of Supervisors in strong support.
Thank you. Seeing no additional witnesses in support, witnesses in opposition? Seeing none, let's go to questions and comments from committee members. We have a motion. We have a second. Any questions or comments? Seeing none, the motion is due pass as amended to appropriations. Madam Secretary, please call the roll.
Bonta?
Aye.
Bonta, aye. Mainshine? Aye. Mainshine, aye. Bonilla? Burke? Burke, aye. Chavez? Aye. Chavez, aye. Chu? Gomez? Gonzalez? Hernandez? Lackey? Aye. Lackey, aye. Nazarian? Patterson? Patterson, aye. Ridley Thomas? Rodriguez. Santiago. Stein North. Aye. Stein North, aye. Thurmond. Waldron. Waldron, aye. Wood. Wood, aye. 8-0. That's 2 more.
The current count on your bill is 8-0. Again, quite a few members are currently away from the committee, so the bill will remain on call.
Thank you, Mr. Chair, members.
Thank you, Senator Lara. I see Chairman Hernandez with quite a few bills here. We have item number 3, SB 36, item number 4, SB 43, item number 5, SB 137, and item number 6, SB 147. Mr. Chairman, whenever you're ready, would you like to start with SB 36?
Thank you, Mr. Chair, members. I just wait till the door closes a little
Absolutely.
bit noisy. Again, Mr. Chair, members, thank you. This bill would require the Department of Health Care Services to submit an application to the Federal Centers for Medicare and Medicaid Services for a waiver that continues the state's momentum and success and innovation achieved under the current Bridge to Reform waiver. You have the identical bill that we have in our House that we will work together on. State's current Section 1115 waiver expires October 31st of this year. The waiver renewal is critical to the long-term physical sustainability of the Medi-Cal program and to the California's ability to continue to provide high-quality health care to its beneficiaries. The last waiver was estimated to draw down $10 billion in federal funds. The DHCS is requesting nearly $17 billion in federal funds in a new waiver. With that, members, I respectfully ask for an aye vote.
We have a motion. We have a second. Thank you, Mr. Chair. Witnesses in support?
Good afternoon. My name is Sarah Muller. I'm the Vice President for External Affairs with the California Association of Public Hospitals and Health Systems. Together, public hospital systems serve just under 3 million patients every year, the overwhelming majority of whom are Medi-Cal or uninsured. The 2010 waiver was critical in California's effort to lead the nation in ACA implementation, and many of the state's new Medi-Cal enrollees benefited from the waiver's low-income health program and from improved care through the DSRIP, which was the pay-for-performance program for public health care systems. SB 36 and the state's effort to secure a renewed waiver will be equally important to ensure long-term ACA sustainability in our state. It will help build on the early coverage and great coverage success that we've had and install or incentivize payment reforms and other improvements of care so that plans and providers are all working towards the same goals, towards improved health outcomes and health for patients. For public health care systems, the waiver represents a critical source of federal funding that supports our efforts to achieve system-wide transformation and ensure that we can continue to deliver high-quality care to the millions of patients we serve. I respectfully ask for an aye vote. Thank you very much.
Thank you. Additional witnesses in support, please.
Chair and members, Michelle Cabrera with SEIU California, and we too are in strong support of SB 36 as it directs the state to apply for an 1115 waiver, which will help transform our Medi-Cal and uninsured safety net. It will bring $17 billion and cover the entire Medi-Cal program. It will also include important programs to advance workforce training and development and promote better equity and reduce disparities within Medi-Cal. And for all these reasons, we're in strong support and urge your aye vote.
Thank you. Additional witnesses in support.
Angela Gilliard with the University of California on behalf of the 5 academic medical centers in support.
Greg DeJere with the ARC and United Cerebral Palsy California Collaboration, a coalition of people with intellectual and developmental disabilities and their families, friends, and service providers. People with developmental disabilities, adults with developmental disabilities overwhelmingly have poverty-level incomes and depend heavily on Medi-Cal, and we support the bill.
Pete Nielsen, Deputy Director for Addiction Programs and Professionals in California, and we're in strong support. Removing the IMD exclusion will greatly improve addiction treatment services in California. Thank you.
Just a reminder, please, that this is stating your name, organization, and position only.
Christina Romero, Planned Parenthood, in strong support.
Catherine Oskin-Scott, District Hospital Leadership Forum, in strong support.
Jean Hurst here today on behalf of the California State Association of Counties and the Association of California Healthcare Districts in strong support.
Fred Main on behalf of CalPACE, the program for the all-inclusive care for the elderly, in support.
Kieran Savage Sangwan on behalf of the National Alliance on Mental Illness of California, in support.
Chair and members, Sean South with the California Primary Care Association, in support.
Thank you. Seeing no additional witnesses in support, any witnesses in opposition? Seeing none, any comments or questions from members? Seeing none. We have a motion. We have a second. The motion is due pass to appropriations. Mr. Chairman, would you like to close?
Ask for your aye vote.
Thank you, Mr. Chair. Madam Secretary, please call the roll.
Bonta?
Aye.
Bonta, aye. Mainshine? Aye. Mainshine, aye. Bonilla? Burke? Burke, aye. Chavez? Aye. Chavez, aye too. Gomez? Gonzalez? Hernandez? Lackey? Lackey, aye. Nazarian? Patterson? Patterson, aye. Ridley Thomas? Rodriguez? Rodriguez, aye. Santiago? Steinnorth? Thurmond? Waldron? Waldron, aye. Wood? Wood, aye.
The current vote tally is 9-0. Mr. Chair, that bill will remain on call. As additional members come back, we'll ask them to vote.
Thank you, Mr. Chair and members. I'd like to take up SB 43, if you don't mind.
Please do.
Mr. Chair and members, I'd like to accept the amendments described in the analysis. Comment number 5. In 2012, the California legislature enacted legislation authored by myself and Senator Manning to establish the California Essential Health Benefit Act under the Affordable Care Act. Earlier this year, the federal government issued new regulations requiring states to update their essential health benefits based on a 2014 benchmark plan. The new regulations also create a definition of habilitative services, which is a more generous one than California's current definition. This bill is the vehicle for the statutory changes necessary to conform to federal requirements. The actuarial firm Milliman has conducted a comprehensive analysis of California's benchmark options and concluded that the benchmark options are all comprehensive, but there are some services that have differing coverages. These differences produce relatively small differences of average health care costs, ranging from 0.2% to the lower to 0.4% of the higher than California current essential health benefits. We have heard from the stakeholders a desire to change the benchmark from the current small group plan to CalPERS plan because of the richer benefit that would be available using the CalPERS plan as a benchmark. I appreciate their perspective, but I am mindful of the impact this will have on affordability of insurance premiums. Almost half of newly insured adult Californians find it somewhat or very difficult to afford their monthly premium. Over 44% of covered California policyholders have trouble affording their premiums. The main reason the uninsured gave for not enrolling is that it is too expensive. Milliman found a slight increase in costs. If so, we would move to CalPERS plan, but Milliman did not analyze the costs associated with a broader definition of habilitative. The administration has also indicated preliminary to the federal government that the California's choice is the small group plan. And with that, members, I respectfully ask for an aye vote.
Thank you. Witnesses in support, please.
Beth Capel on behalf of Health Access California. The essential health benefits is one of the very important improvements that the Affordable Care Act brought for individual and small employer coverage. It set for the first time a floor under individual and small employer coverage comparable to that for large employer coverage. In addition, California improved on the federal requirements. So the benchmark plan that is in place today that this bill continues is better than the federal government requires. So we were in support of that then. We're in support of that now. In addition, this bill makes very important improvements for children with disabilities to assure that they have the benefits that they need that are comparable to those that others have when they have rehabilitation to maintain or reduce the rate of loss of development. So the definition of habilitative, a term that was not known to us prior to the enactment of the Affordable Care Act, now defined in federal regulations, a very important change in terms of providing services to children with commercial coverage. We would note that much in addition to the affordability concerns that Senator Hernandez noted, that there are Californians who are actually priced out of the requirement to have coverage because coverage costs more than 8% of their income. In addition, for small employers, this is a voluntary market. They may choose to provide coverage or not if they have fewer than 50 employees. So for those reasons, we're in support of this bill as it is before you today.
Mr. Chair and members, Elizabeth Landsberg with the Western Center on Law and Poverty, and we would concur with the importance of having a base level of benefits provided by all individual coverage and all small group coverage. We're in support of the changes around habilitative services, and we very much appreciate the author taking the amendment to clarify that the pediatric dental benefit is actually the Medi-Cal benefit, which is a very important change. We're here in support. Thank you.
Additional witnesses in support.
Good afternoon, Mr. Chair, members. Gregory Kramer on behalf of Planned Parenthood Affiliates of California in support.
Melissa Cortez Roth on behalf of Autism Speaks and the Center for Autism and Related Disorders in support.
Chair and members, Sean South on behalf of the California Primary Care Association in support.
Thank you. Witnesses in opposition? Concerns? Or support if amended?
Yes, support if amended. Janice Rocco, Deputy Commissioner, California Department of Insurance, on behalf of Insurance Commissioner Dave Jones. We're a support if amended position. We're seeking amendments to the bill to change the selection of the Kaiser 30 small group plan to the Kaiser CalPERS plan so that important health benefits would be added to the policies that are sold in the individual and small group market. These are medically necessary and often affect significantly someone's quality of life. Unless the amendment we're seeking is taken, medical benefits such as hearing aids, wheelchairs, hospital beds, patient lifts, respiratory equipment such as oxygen systems, prosthetic and orthotic devices. These are things that will not be covered as essential health benefits, and as such, they will be excluded from most individual and small group products, not only in 2017, but for years into the future since we don't select a new benchmark each year. Obviously, affordability is a significant issue. It's something that our department spends an awful lot of our time trying to make happen. The Milliman study shows that we're talking about a 0.38% increase that would be appropriate if these benefits are added, less than half a percentage point to add basic needs that many people have, like I said, such as wheelchairs and hearing aids. If you have a policy with a deductible of $2,000 or $6,500 as the products in 2016 sold under the standard benefit design will have, and you still don't have coverage for some of those basic services, I'm not sure how you're going to afford to access those services. The only other argument that we have heard about the CalPERS plan amendment not being taken is consistency, and we have seen the policy from 2014 to 2015 changed in the exchange to add pediatric dental. From 2015 to 2016, we are making changes to make sure that prescription drugs, specialty drugs, are affordable. It took 6 months of advocacy to get there. When it comes to essential health benefits, the legislature and the governor make a decision that can't just be changed through advocacy after the fact. So we're hopeful that you will make this change. It's not too late to do so, so we would ask for that amendment. Thank you.
Thank you. Additional witnesses? Witnesses in opposition?
Bryce Doherty on behalf of the California Orthotic and Prosthetic Association in that supportive amended category. Running the risk of having the microphone shut off, I just want to associate our comments with the Department of Insurance. We support adoption of the CalPERS HMO. Not to put too fine a point on it, but the issue with the new definition of habilitative services, which we would agree is an expanded definition of coverage, the current Kaiser HMO Small Group 30 plan, as the benchmark, only covers certain orthotic and prosthetic devices. Laryngectomy devices, mastectomy, and some other reconstructive surgery sorts of devices. The CalPERS HMO plan has no annual deductible and covers the full range of orthotic and prosthetic devices which are intended to either replace or restore function, specifically for extremities and specialized footwear. So for those reasons, we ask for adoption of the CalPERS HMO and support if amended. Thank you.
Shannon Smith Crowley, representing the American Society for Reproductive Medicine. We're also in a supportive amended position and would ask you to consider the CalPERS option. Nowhere else have I heard any discussion about infertility coverage, and the CalPERS option would give basic infertility and artificial insemination coverage. It would not include the more expensive in vitro fertilization. People in their 20s and 30s often they're otherwise healthy. They don't go to the doctor. And it's important to get an infertility workshop as soon as there's any concerns. It may also expose underlying health conditions that's causing the infertility. So we ask for this amendment. Thank you.
Thank you. Any additional witnesses in opposition? Seeing none. Any questions or comments from members? Mr. Lackey.
Yeah, my only question is, what is the likelihood that you would be willing to take any of these amendments? Because the essential services like a wheelchair seem to be pretty basic.
At this point, I'm not prepared to. I'd like to move forward with the Kaiser Small Group, and for me, I think it still comes down to overall cost. And as I mentioned in my opening statement, that's the number one concern that Cover California has. Thank you.
Additional comments or questions from members? I just want to state that while it may be tempting to expand the benchmark plan to cover more benefits, I think it's prudent to keep our current benchmark in place. Our benchmark plan is relatively new, and we got to keep it in place rather than change it as we continue to implement and adopt the ACA. Affordability of coverage is also a priority. We need to bear that in mind. There could be, and there will be, cumulative impacts of costs, even if the CalPERS Kaiser plan seems to not have a significant cost addition on its own. So with that, I'll support the bill today with the Kaiser Small Group HMO as the benchmark plan and with the amendments taken by the author. We have a motion or a second yet? We can entertain a motion. We have a motion and a second. Mr. Chair, would you like to close?
Respectfully ask for an aye vote, Mr. Chair and members. Thank you.
Thank you, Mr. Chair. Madam Secretary, please call the roll.
Bonta?
Aye.
Bonta, aye. Mainshine? Aye. Mainshine, aye. Bonilla? Burke? Burke, aye. Chavez? Chu? Aye. Chu, aye. Gomez? Gonzalez? Gonzalez, aye. Hernandez? Lackey? Lackey, aye. Nazarian? Patterson? Patterson, no. Ridley Thomas? Rodriguez? Rodriguez, aye. Santiago? Santiago, aye. Stein North? Thurmond? Waldron? Waldron, aye. Wood? Wood, aye. 10 to 1.
Your bill passes with a vote of 10 to 1.